too, right, and all the lighting.
Right. So I have to ask, so you recently retired, end of, 2018, I believe?
Well, I retired from clinical practice at the end of 2018.
And that was sort of the second retirement, right? There was a softer retirement initially.
Yeah, there have actually been 3 retirements. I retired, of course, as the department chairman already back in 2014. I retired as the chief of the Ocular Oncology service at the end of 2016. And then, of course, I actually had my retirement celebration here in Cincinnati in July of 2017. It's 2018. It seems now longer ago than it was. But at that point in time, I thought that I was going to be stepping down at that point in time. And I thought Dr. Correa was going to be continuing the ocular oncology service, and I would just be a consultant periodically. Well, it turned out Dr. Correa got offers from a couple different places and decided to go to Johns Hopkins. She stayed coming back to Cincinnati periodically for the next 6 months or so. So it was kind of a slow transition, but all of a sudden I was faced with continuing to see patients until we had a new replacement. Fortunately, we were able to recruit Basil Williams, and he was able to start in October. So I continued to see patients full-time from July through October. As he got there, I saw patients with him for the next 3 months just to kind of introduce him to things. And then at the end of that time, I let him take over. And my final retirement from that aspect of what I was doing was at that time. That doesn't mean I'm retired, though. I'm obviously here on a Saturday today, and I'm here most Saturdays and Sundays for at least a few hours, as well as 5 days a week. I still have pretty much 8-hour days or more, just going through my charts, doing some retrospective clinical research studies.
So I just came off the retina rotation, so I was with Dr. Williams, but I noticed there were still some patients you were seeing or who specifically requested to see you. Is that still something you do on a week-to-week basis, see a patient here and there?
Reluctantly. I'm doing it pretty much. I would prefer that I only see them if he wants me to see them in consultation. Once in a while, though, if it's an exceptional patient that he had never seen before and they're coming back after many years, I will go by and just take a look at them briefly, see if there's something that needs to be done, in which case I'd make arrangements for him to follow up with them.
Gotcha. And I also saw sometimes you'd be in the OR when we'd be doing biopsies or taking specimens. Are you still visiting the OR
I'm not really doing that very much. I went there primarily to familiarize him again with how things were set up for us to do the various surgeries that we did, introduce him to the various people. But more than anything else, I was there to help with processing the fine needle aspiration biopsy specimens so that we would be sure we got an adequate aspirate for the testing we were doing, both cytology and gene expression profile testing.
Right. Well, I imagine it can't be easy to come to a new university and sort of pick up where you've kind of left things. So I think that's great that you were able to step in and helps that transition, even though it might have ended up being a little bit longer than you anticipated.
Right. I think it helped him a bit to get acquainted with the system and know where he was and know how things had been done. That didn't mean, of course, he needed to continue to do them that way, but it certainly, he was familiar then with our setup.
Right. So you mentioned you were here on a Saturday. You come in on Sundays for a couple hours. You're here 5 to 7 days a week,
right?
Even though you haven't officially retired.
Right.
I don't know anyone who post-retirement would do that. Most people, I think, when they're done with their career, so to speak, they set sail and they rarely look back on the shores of their work. You are here, still very much in it, and I have to ask, what gives you that passion? What gives you that drive to keep wanting to come in every day and continue to do your work?
It's something that I have that almost no one will have in the future, is a collection of accumulated patient charts that are hard patient charts, paper charts, that are filled out primarily by me with diagrams and notes and photographs that I've taken in those charts that look back on 40 plus years of practice. Today, with the electronic medical record and shared patients across all kinds of services, the ability to have your own records is a thing of the past. So I've even discussed this with some of my colleagues around the country. I know when I was in Baltimore a few months ago, I mentioned what I was doing, that I was reviewing all of my old charts so that I could then form a complete patient name diagnosis database that then could be mined retrospectively to look at patients with different kinds of tumors, different kinds of simulating lesions, different kinds of treatments for certain things, different kinds of diagnostic techniques such as needle biopsies, and that sort of thing, and do that until I had at least a good retrospective descriptive idea of what had happened to those patients over the years. My principal goal in all this is with the uveal melanoma patients to determine whether there's been any improvement in survival for substage specific extents of the disease. It's my impression that there really hasn't been any, in spite of all kinds of new targeted therapies that have been developed for uveal melanomas. And the way we'll do that is I'll look at the survival follow-up of all the patients, and for those who I lost to follow-up, we'll submit their names to what's called the National Death Index of the United States. It's a comprehensive death index. You have to pay a fee, you have to have an approved protocol to do it, but as you do that, you can then at least find out if they've died as of a certain date and when they died. Now, I won't be able necessarily to tell on those patients lost to follow-up why they died.
Right, what the cause was.
But the important thing will be to compare all-cause mortality relative to the date of treatment and for the substage-specific categories of those patients. Because if there's no difference in all-cause mortality, there can't be any difference in terms of melanoma-specific mortality.
That's interesting. So there's actually a national index or service where you can figure out after applying whether or not someone has passed on.
Correct. And I've used that ever since, I believe, probably about 1985.
Oh, wow.
Periodically, I've surveyed it.
So this is a long-standing service.
Oh, yes. It's been around for a long time.
Is it? I'm assuming it's specifically only used for medical science, or?
Yes, really it is, for primarily medical science and for oncology more than anything else, because we're interested in the follow-up of those patients.
Right. So you mentioned to me, I think it was last week, that as you've been going through these charts, you have to go through it in multiple passes, and you're currently about halfway through the first one.
All right.
What
the
does
multiple
that look like?
passes are, I have to review every individual chart. I have to remove or discard all the charts of patients that I have no interest in the long term. Posterior vitreous detachment, scratched cornea, did an UBM examination at someone's request for uveitis or lens position, things like that. Those are just getting discarded. Of the ones I'm retaining, I'm going through them page by page. I'm eliminating all duplicate pages, all blank pages, all unreadable pages, all extraneous pages, meaning things like the billing information on these patients, etc. And once I've done that, I'm taking the retained pages and making sure they're in chronological order. For any of the patients with fundus tumors, we have the fundus drawings and photographs and ultrasounds and other documents for them. I'm always checking the drawings because some of the earlier drawings were not well prepared. Especially when you're talking about larger tumors, ciliocoroidal tumors, it wasn't often put in the record very well where the posterior margin was, what the full extent of the tumor was. And if someone like a medical student or a resident or someone else were to survey those charts and try to figure out how big was this tumor based on some notes that are in the chart, he or she might be very misled by that. So I'm going back and either correcting the drawings that are there, or in some cases making a revised new drawing of that to correctly represent what was there, taking into account everything we know, including, when available, the pathology information. And I think it gives me a much better idea of exactly what we were looking at in terms of, again, substage specific categories. So TNM or whatever other categorization you want to use, you need to know exactly the tumor dimensions and what tissues they involved in order to make that determination. That's why those are so important. And so I make all those changes in there. Then I also mark on the individual drawings my estimates of the accurate dimensions of the tumor. If they were small melanocytic choroidal tumors, I marked down whether there was or was not subretinal fluid, whether there were or were not clumps of orange pigment, whether there were drusen and or clumps of retinal pigment epithelial abnormalities overlying the tumor and attributable to the tumor. I also marked down where the tumor was located relative to the optic disc and fovea. And those, again, are all important in terms of various kinds of outcomes that we might look at. Once I've done that, I have to still go back to the chart and the inside front cover and make a notation about my diagnosis now, based on all that I know, not necessarily what I said the tumor was when I saw it the first time,
right,
but what I think it is now. And one of the things we will do later on is look back at how often the diagnosis that I make now differed from what we called it years ago. After that, we also mark in the front inside part of the chart the treatment that was given, if any, and the follow-up that was there in the clinical course. Some notations about that, including if they developed metastasis and when, and whether they died or not. So it's a very quick way of me just opening the front part of the chart now without having to go through it real quickly and know what the diagnoses I'm going to be recording on my name diagnosis list. So the next time I go through it, we can then get those lists prepared. So as I go through it, I'll have to record the name, diagnosis, management, things like that, but all from the inside front cover of the chart. Once I've done that, all of that information, of course, will have to be transcribed into a computer program, a database, where then I can analyze the individual subgroups. And we'll have to go back through those then again to abstract the specific information that's relevant to each of those kinds of cases.
And you have 40 years worth of data.
Yeah, we have, I've estimated there's about 13,000 charts.
Wow.
Right there that I have. And so far I'm eliminating about, it appears to be about 1 in 15, 1 in 12 perhaps, of the charts. So it's a substantial number of those are going to be pitched out, but it's still going to leave quite a number of them to deal with.
Right. How many do you think you've gotten through so far of the initial pass?
Of the initial ones, I've gone through, I think, about 40%.
Okay.
That's been since since April of 2019 until now.
And that's you coming in almost 7 days a week working on that. That's quite a feat. Something that's interesting that I thought about is how many of those times where you look at those charts and you notice there's a discrepancy either in the size of a tumor that's been drawn or on a fundus photo, whether that discrepancy is between one of your previous exams or one of your exams after that. How many of those cases involve when a medical student or resident was documenting things?
Well, quite often I have some classic instances where the drawings that the resident or certainly medical students, I don't expect too much of them, but the residents and then certainly the fellows, it would be grossly misleading, and I would have to go back and either discard them or try to repair them if I could. And so that's been a classic thing that people know me for, about critiquing their drawings, and my impression is that most people don't have a good understanding of what the drawings, the two-dimensional fundus maps that we have, are supposed to represent when we're looking at something in the fundus. We're not just making a nice, pretty drawing. We're trying to make a map that accurately depicts where the specific lesion is in the fundus relative to all relevant anatomic landmarks and how big it is, and associated features with it. So there are all those things that are important to record, and many times, let me just say, over the years, I found 4 different kinds of drawings that can be made. One is what I will call the stick figure drawing. That means somebody kind of knows which quadrant in the fundus it is in and kind of makes a little circle over there, and it has nothing to do with reality most of the time, and also it looks terrible.
Yeah.
Second one is one that is actually, again, it's kind of a stick figure thing, but at least the individual has taken the time to try to get the position correct and the dimensions about appropriate, and it doesn't look real nice, but it's actually a pretty good representation of the map that you would want. The third one, which is probably the most dangerous of all of them, are some of the residents or fellows have made very pretty looking drawings, and they look real nice, and they shade them in and they color them in, and they have very little to do with reality. In other words, they don't really depict where the tumor was accurately or how big it was.
That's interesting.
And yet it looks nice on the picture. And those are very dangerous, because you'd be inclined to think, oh, that's going to be wonderful, and it's often not. And the fourth kind are the ones like I do, which they're good maps, they're anatomically correct in terms of the localization, and they look pretty good. So that's nice.
I would agree. I think you at least. So when I rotated through, it was Dr. Williams in the clinic. But when I was a medical student, I spent a month with you and Dr. Correa, and was able to try my hand at doing those fundus drawings on the regular. And I remember some of the other residents, the more senior residents, telling me how their drawings would often be erased, or they would put a X instead of a plus for the fovea, or vice versa. And I think that just speaks to how meticulous you really wanted your records. Do you think the discrepancies, barring residents or medical students making the drawings, do you think there's some issues in terms of reconciling them because 20, 30, 40 years ago, you didn't have your eye so much on this kind of research, and it's only as you've gone along throughout your career that you've realized, I need to start documenting things more carefully if I want to look back and sort of mine the data?
Yes, I did. Let me just say, I started looking back at the data that had been accumulated in the Ocular Oncology service at Wills Eye Hospital, where I was for many years, shortly after I joined the group in 1980. Dr. Shields had started on a part-time basis there with that in about 1974. But just to put it in perspective, by the time I joined him, he had done 40 radioactive plaques. And now, each of us, I've done more than 3,000 of them. I don't know exactly how many, but when you think about where we were, when we started out, we used to have diagrams, for example, that were, I will show this one to you, but but what it is, it shows the fundus of each eye just as a circle without any additional circles indicating where the ocular equator or a serrata, base of the pars placata is. It doesn't show, it shows incorrect positions of the optic disc, especially in the left eye, if you'll notice how far over it is to the nasal side. And then they have cross-sectional diagrams on that form as well. And you might notice that according to that form, the right eye is always axially elongate compared to the left. I have no idea why the charts were prepared that way. And our basic follow-up sheet was just a lined piece of paper many times. And so many of the early diagrams that I came across that had been done by Dr. Shields and by the residents and fellows up to that point in time were virtually uninterpretable. And so that really prompted me very early on to start to insist that we make better diagrams than had been done up to that time. Now, we also at that time used primarily the standard Scapin's drawing chart. I don't know if you've ever even dealt with those, but the standard Scapin's charts are, well, you haven't seen me use those actually, because the real ones are 9 inches wide.
And these are,
and they were made up by Scapin's and the Retina group in Boston to reflect the appropriate size of the drawing if you used a 20 diopter lens. Well, one of the things I learned early on is to see many of the tumors that we were looking at, it was more helpful actually to use a slightly higher power, smaller diameter lens, a 28 diopter lens. And it gave a wider field of view, but if you're recording things the way they look with the 28 diopter lens, you need a smaller diagram. And so you'll notice that the diagram that I developed then was smaller than the ones that Scapin's and his group had developed and which were in common use up until that time. So I insisted that if you're going to draw things, you need to have some sense that what you're going to be diagramming is comparable in size to what you're seeing on in your lens. All right, so that was one of the things. I also worked to get some diagrams prepared that showed the residents and fellows where everything was, where things like this line represents the equator, this line represents the ora serrata, etc. And then also describe to them what the zones of the fundus were. It had always kind of bothered me, almost like fingernails on a scratching on a blackboard. When I would hear that something is in the mid-periphery and it was 2 millimeters from the optic disc. Well, what's if there's a periphery? How can there be a mid-periphery? And so some of the zone descriptions people were giving were very bad. Now, I was fortunate when I started out. I need to let you know that I started making retinal drawings regularly when I was a second-year resident. I would go around to see virtually every retinal patient there was, and sometimes torture them each for an hour or more, keeping in mind back then retinal patients were admitted to the hospital, typically a day and sometimes more before their procedure. So you had a chance to meet them that evening after your clinic work, go over there, see them, torture them, make your fundus drawing. And I did ones where I was trying to show every dentate process, and if there were abnormalities of the dentate processes, to show those, to reflect, of course, every little retinal break that I could find. And I was helped by three real things that came out shortly after I started in that. First, while I was a resident, it was called to my attention that there was a nice article by Stratzma, Foos, and Spencer that was back in the Transactions of the New Orleans Academy of Ophthalmology Symposium on the Retina in 1969. And in it, they had made various anatomical measurements on various parts of the eye to show exactly how large things really were, not how big we estimated them to be a lot of times. The second one was a series of articles by a fellow up in Boston in the Scapins group, Utai Rutnan, and he, along with Scapins, then published a series of articles in AJO back in 1967 that talked about what is the standard peripheral fundus, what the choroid normally looks like, what normal variations are. And they had lots of color plates associated with this. Well, I read those things in detail, and I went back and I tried to identify every single one of the things that they had talked about in those diagrams. I often tell residents at this point in time, I was lucky back then in two real ways. Though one, because we had admitted inpatients that I could take my time and just see them as long as I wanted to. But the other one was that it was an era when we were still doing intracapsular cataract surgery, often with a superior peripheral iridectomy, sector iridectomy. I'm sorry, not a peripheral iridectomy, a sector iridectomy. And patients didn't get an intraocular lens, and they were wearing aphakic glasses. So in those patients, even without scleral depression, you could see up to the pars plana without any problem, superiorly at least. So you knew what it was supposed to look like. And so then if you could see that with scleral depression, you could see it nasally, temporally, and inferiorly too, and know if you were really seeing what you could see.
Yeah.
So those two things were advantages that I had that residents don't have today.
But even with those advantages, was what you were doing sort of the standard in your residency, or were you sort of an outlier?
Oh, no, I was greatly an outlier. I was the only one who was doing that at all. I don't know why. I mean, it's one of the things. When I was a kid, I did some artistic things. I had an art teacher, this is always just a rather amusing aside, who thought I was going to, when I said that I would be going to medical school eventually, she thought I was throwing my career away.
Wow.
To go into art. Well, she was wrong. But nevertheless, I had some of that ability already.
You had some talent. You had a natural inclination.
I did. And then this idea of understanding the three-dimensional topography of the inside of the eye, I think I had that perception better than most of the other residents too. And I've always felt that we go into things that we like, mm-hmm. and we often like the things that we do well, or at least substantially better than our colleagues. And so those were things that I did that really did stick out. I will also tell you, once I started to get familiar with how to do indirect ophthalmoscopy too, I started to go around even to the other hospitals, to Good Sam, for example, where they had a big pediatric neonatal unit, and I started to do all their ROP exams as a resident. Nobody asked me to do it.
Right.
I went down to radiation oncology here and asked them anytime they were going to be seeing, cancer patients that they thought might have metastasis, would they call me? And I'd go down there and I'd see them. And so there are a lot of things that I just did. I can't even explain why.
No, I mean, that's remarkable, and that's the kind of dedication you don't really see today.
One of the things I did in developing the charts that we have too, because I wanted to make sure I understand them correctly, I would occasionally make charts looking as if you were looking from the opposite side. All right, you're looking from the back. If it were transparent, toward the front, so that if you had something in the ciliary body and iris, how would it look if you were behind the patient looking in? And so I would make the diagrams both from the front and the back. The last thing that I did, I actually even made a few while I was a resident that were stereoscopic. So I would have two drawings, one here, one there, one to the left, one to the right, and I would draw one with my left eye open, but my head in the same position, the other with my right eye open to show where the things were. And then when you would fuse them with like we used to have reading glasses for fluorescein angiograms that were printed. When you'd look at those, you could fuse them actually and see things in 3 dimensions. So
I don't know what to say to that. I feel so inadequate. I need to step my game up in residency.
But going back on that, you also need to know that back at that time, most ophthalmologists in the community didn't do indirect ophthalmoscopy at all.
Really?
Most of them just used direct ophthalmoscopy. Indirect ophthalmoscopy really even only became widely available with the Scapin's kind of indirect head-mounted indirect ophthalmoscopes by the, I'll say, mid to late 1950s, early 1960s. But most of the people who had gone through residency prior to that time never developed that ability.
Interesting.
And so when I came here as a resident, there were only a couple people that ever even used an indirect ophthalmoscope. So I felt that right away I needed to learn how to do that. I tried to learn how to do everything, I must say, too. Back then we had very primitive ultrasound machines. I taught myself how to do that as well. It was just one of the things I liked to do. I didn't even know necessarily I was going to go into retina at that time, but I needed to know how to do everything.
Hearing this, it's no surprise to me. You've had the career you've had, and I do think ocular oncology, maybe ophthalmology as a whole, is one of the few, maybe the only specialty in medicine and surgery where you really get to express your artistic side. I remember the first time I walked into one of your clinics and I saw the container with the colored pencils, and patients would walk in and they knew you and they say, oh, he's going to pull out his colored pencils and do his drawing. But you've been doing this in residency, and you told me a story once when you were on the fellowship trail, I believe. You carried your fundus drawings with you. Is that correct?
Right. And I thought I was even going to bring some in here with me today. Back then, because I was making them, and I felt that they were part of my record more than the patient's record. Mm-hmm. I probably incorrectly so, but I kept all the fundus drawings I made during residency.
You still have them?
And I still have them.
Wow.
At any rate, I did take a number of them along with me, especially the ones that were retinal detachment related, and because I was then at that time applying for retina fellowships. Interestingly, it's very different then versus now. I decided at that point in time I was only applying to 3 places, which I thought were the best 3 places in the country. They were the Boston Retina Associates with Charles Scapin's and group. There was the Wills Eye Hospital Retina Service, and it was the Bascom Palmer Retina Service. And so my first interview, I went up to Boston. I got to sit there during my interview time with Dr. Scapins at one end of a long table, and the other 15 members or so of the retina group around the table, and you're there for about 15 minutes, and they all ask you questions, and that's fine. I recall it was in the evening before they interviewed us that day, and as I was done, I said, thank you, but now how do I get out of here? And they say, you just go down this hallway and right out that door. And I went down that hallway the way they said, and there's a door. It says alarm will sound if you go out this door. I said, well, they must have turned off the alarm or whatever, so I go out the door, the alarm sounds.
The day this is after the fellowship interview.
Yeah, right after the fellowship interview. So I figure, well, my fellowship interview's over. I've just messed everything up. The next day, they called me saying that they would take me if I wanted that position. And the only thing I could ever understand about that is they must be testing you to see if you would follow instructions. And interesting, I thought. Anyway, my second one then was to Wills. So I went to Philadelphia, and I did take my drawings along there as well. And I remember going into the interviews, and one of the guys said to me, essentially, well, what do you do better than anybody else here is applying? And I said, well, I make good drawings of retina. I'm a good observer. And I said, I'll show you some. And I brought these out to him. And he was impressed. This is Dr. Serene, Love Serene, who was going through it. And Dr. Tasman came up at that time, and he looked over his shoulder at those. And he grabbed one of them. He took it out to the next room, and he holds it in front of one of the fellows at that time. He says, why don't your drawings ever look like this? And so I think that had a major influence in my getting they accepted me there as well. They offered me an interview at Bascom Palmer after that, but my wife and I talked about it. We liked the idea. She was from about 2 hours west of Philadelphia. She liked that idea, so we just decided, let's go to Philadelphia and not even take the interview at Bascom Palmer. Interestingly, I had said earlier on that if I didn't get accepted by any one of those three places, I would just go into general ophthalmology practice.
Wow. But all three gave you interview offers, and you went on two of the three. So you did your residency here at University of Cincinnati.
I did.
You did your fellowship at Wills.
Yes.
And you met your wife at Heidelberg.
I did. Heidelberg is a small college in north central Ohio.
And I think I remember, and you recently did an interview with Heidelberg, and you were describing your schedule and how regimented it was, how rigorous it was, your study routine.
Yeah, when I was in high school, I was in a rural high school where the academics were not very strong. We didn't have any advanced placement kind of courses at all. And very truthfully, I did not work very hard, and I still was. I think I came in second in my class without really trying. At any rate,
this is in high school?
This is in high school. This
yeah.
is in high school. So when I went to college, I said, for the first time, I'm really paying for this. And unlike many people went to college thinking this is going to be a life experience and I'm going to grow up during this time. Well, that was not how I looked at it. I looked at it as, I'm paying for this. I need to get something useful out of this. And I said, if I'm going to be doing this, I'm going to be sure that I'm applying myself appropriately. So I developed classic kind of a schedule that was for at least 1 hour of study time for every hour of class time you had that week, or in any given day. And I essentially made it so that I got up at a regimented time. I think it was about 6 o'clock every day. I was always the first one in line for breakfast. I had breakfast. I always had classes that started, I think, at 6:50 in the morning. And I would take all the courses I could take during the day. But my then schedule after that would be 50 minutes of study, a 10-minute break, 50 minutes of study, a 10-minute break, and I would do that until 10:50 at night. I would go to bed at 11.
Wow.
Every night. If I had an exam, I would, or more than one exam, I would give myself one additional hour that evening. So in other words, instead of going to bed at 11, I would go to bed at midnight. But I never stayed up later than midnight. I never crammed for a single examination, and I did come in first in my class at Heidelberg. Now, that's not the same as if I had gone to some major university, but still, it reflected the fact that I did well. But more importantly for me is I got something out of it. I got to take courses in embryology, in comparative anatomy of the vertebrates, in physiology, of course, in organic chemistry, and all sorts of things that were relevant to what I eventually did. And I was very happy with my experience there.
I think a lot of medical students or residents can probably relate to sort of a rigorous schedule like that. But what did you do to decompress? At least in my experience, it's you can keep up that kind of work ethic and routine for a while, but eventually, if you don't have something keeping you sane or helping you just relax in between, it eventually falls apart.
Yeah, my one outlet was I was a member of the college concert choir for all 4 years, and we would have various concerts around. We had practices every week, but we would have concerts around the continental United States. The first 3 years that I was there, and then the fourth year in 1970, we actually had an international tour to Europe. And so that was my major outlet. Beyond that, I didn't do very many social things at all. And those of the people who know me are not surprised by that.
It's interesting. I think maybe back in undergrad or in those earlier younger days, I would have looked at a situation like that and been like, man, all he did was study. He didn't really socialize or go out. But now in retrospect, especially as a retina, I said, wow, what kind of ability can someone have that early on to be able to lock in, be absolutely focused, committed to what they're doing, try to accomplish a goal? So I really think that's remarkable. At what point in Heidelberg, or maybe even before going to Heidelberg, did you realize or come across the decision to go into medical school?
I always make the joke that I decided I would go to medical school after I was too old to be a cowboy or a fireman. And once I really recognized that I didn't have the ability to play Major League Baseball, which is what I would have liked to have done.
Is that something you seriously were pursuing?
Oh no, of course not. I was a legend in my own mind, as they say.
Aren't we all?
Yeah, well, yeah, I guess that's good that we are, but that was something that I really thought I wanted to do, but my eyesight is too bad for that. I'm certainly not any physical specimen. I'm not, I liked it. But I recognized at about age 13 that I wasn't going to be able to do that. And after that, I noticed, I looked around at various people. I knew a lot of people in our community who worked in factories. During summers, I worked in factories too. I didn't want to do that. I knew I didn't want to do that. My father was a postman. I knew I didn't want to do that. My mother was a teacher. I knew I didn't want to do that either. So I looked around at various things. I said, that's something I could do. I think I would be a good physician. And from that moment on, I was very focused. But again, the focus didn't take place until I started in college, because high school, mainly I played basketball, baseball. Everything else was in the choir, did all kinds of things in plays and whatnot, but I didn't really apply myself very hard.
And then that decision to eventually go into ophthalmology, was that something that came about much later, or near that decision to go to pursue medicine?
Yeah, that's hard to explain. My first, I was the classic myope who at age 10 got to the optometrist for the first time and came out with that wow experience that now I can actually see things, and I didn't know that I was missing all those things. So I had a very favorable experience with that, so I really liked that. Second one was my brother, who's about a year and a half older than I am, went into optometry. He went to Ohio State University. He really enjoyed himself, and he a lot of times would have some of the books about his optometry hanging around. I would go through them. I was interested, I must say. I thought, wow, this sounds pretty fascinating. I wasn't interested in going into optometry, though. I still thought I was appropriately destined for medical school. You also need to know my mother had developed a leukemia about the time she was 40, eventually died of it when she was, I think, 49. And that had an impact on me as well, about how disease can really change your plans. Both my brother and I, because of that experience that she had, both, I think, thought that our lives would probably be relatively short. We would follow in that pathway, and therefore, if we were going to get anything done, we better do it pretty quickly. So that was number one. My idea was, though, still to go into medical school. My brother, who went into optometry, couldn't stand the sight of blood. He would almost pass out with it. That was not me ever. And so I went in with an open mind, and I really must say I liked everything in medical school. There really wasn't a specialty that I didn't like at least part of. But I just gradually gravitated back toward ophthalmology because I liked it. Again, I could do my direct ophthalmoscopy back then. I mean, I would go around and look at every patient that I knew of in the hospital who had anything wrong with them, and get my other colleagues, members of the class, to let me know. And a lot of times, if they had questions about eye things, before they would ever get a consult, they would call me, and I would go over and look at it and at least tell them what I thought it was, and they could decide then whether they wanted to even have a consult. So that was fun. So I look back, and my classmates, just like, when you walk in, this guy's going to be an emergency room physician, this guy's going to be an orthopedic guy, this is a pathologist, right, this is a psychiatrist. Well, they all say they knew I was going to go into ophthalmology from day one. I didn't think I would, but I did.
Yeah, I can kind of relate to that. When I was in medical school, I really enjoyed learning about everything. I found, like you said, something I enjoyed about all the specialties. I found the learning process intellectually stimulating, but then after becoming a third-year medical student and experienced everything on the rounds, I realized there's only a very few specialties I could see myself doing for the rest of my life. Sure, a month here and there, a couple months would be enjoyable, but to really be passionate about something and do it for the rest of your life, I really had a hard time finding anything until I discovered ophthalmology. Right. So when you were in Heidelberg, is that when your mother was diagnosed?
She was diagnosed actually before that. So I often say that I had a child. My brother got married right after high school and left home. So I was kind of the older one. I had a younger brother who was mentally impaired, and my mother was pretty sick. So I was the chief cook and bottle washer and clothes cleaner and ironer and everything else for a number of years. And as she got sicker and sicker, she would bring home things that needed to be graded. So I would be grading, as a high school guy, I was grading papers for these. Fortunately, they were like fourth grade students, so it wasn't anything complicated, but still, I was doing that, forming grade charts for her, and doing various things that I had to do. So I recognized all early on that there were going to be some changes. She died during my second year in college. And again, that just kind of renewed my emphasis on staying hard at work, because not knowing how long you were going to survive, that really had an impact on us.
Sure. I mean, that's a lot to handle, even before undergrad and going through undergrad and trying to become a physician to go to medical school. Do you feel like her diagnosis eventually influenced your decision to go into ocular oncology?
Yeah, it probably did, but exactly how, I don't know. I mean, I never really contemplated strongly going into medical oncology. Just that didn't have any. First, I didn't like the success rates we were having, whereas in ophthalmology, we have pretty good success rates with most things, not all, but most things. And you could make many patients better. But I did learn from my experience on there, again, how to talk to people about cancer problems and not become depressed about it, but being as open as you could. Keep in mind, when I was coming up as a medical student, it was still in an era where you often didn't even tell patients that they had their cancer, which I always found bothersome. Many of the older physicians wouldn't tell them what was going on. And one of the things I wanted to do early on is, as I got into ocular oncology as part of my fellowship, I found again that I could do it better than most of the other people, but I also thought I could do some things better than were being done. For example, when I got there, Dr. Shields would often say to the patient who had a melanoma, well, you have a tumor in your eye, and if we don't take care of it, you could get very sick. And he would kind of leave it at that. And I would say, I'm not going to tell them that way. I'm going to say, this is a cancer tumor in your eye. That right now it appears that it's all contained. And I would go through some things because I recognized what their questions often were. Well, the two questions that, for example, with most patients who have a malignant melanoma, at least starting in the eye, have, is it going to go to my brain? Because it's in my eye, it'll go right back up there. And is it going to blind me? And so I early on started talking about this. Before we talk about anything else that's going to happen, we're going to talk about two things. Number one, first and foremost, this is highly unlikely ever to go to your brain. So let's not even worry about that. All right. It can get out in the bloodstream and go to other places in the body, but that's not likely. So don't worry about that. Second one is, it's highly unlikely that this would ever go over and affect the other eye. So in any case, you are not going to be blinded by that. And you could just see them. Oh, that's so great that we know that. And so I would talk to them that way, but then I would explain what they have, what we expected their outcome might be, or their different routes could be, but never in any threatening way, and always in a very supporting way. And if they needed me to go over it again and again, I would do that.
There's no escaping, though, in ocular oncology. You're dealing with cancer.
Still are.
A lot of patients, most patients who come through have been referred to you by an outside ophthalmologist or provider because they feel like the patient needs an ocular oncologist to take a good, thorough look at them to make a determination. Is this cancer, or is this something benign? Is this just something the patient was born with? There's a lot of stress that comes from dealing with cancer patients. We often, I think, as physicians, take on our patients' burdens or struggles, and inevitably sometimes that can affect us. How have you kind of dealt with that throughout your career? Because these are sometimes very high stress situations, right? If you diagnose someone and say, we might have to do an enucleation.
Right. Well, that, and of course, patients even worse than that are the metastatic cancers that you see already. Those patients have very poor survival prognosis. Or the kids with retinoblastoma and related tumors. Those are even worse, where you have to explain to them. Fortunately, the malignant melanomas, average age when we find one and diagnose it is around 60. So it's not as bad as when you're dealing with things in little kids, because they've got a lifetime, we hope, that they're going to have to deal with this disorder or the consequences of our treatment of the disorder. Whereas at least the older folks, you have to kind of let them know that, well, for example, none of us are going to live forever. I used to have little signs up on in my clinic, actually. One of them always was, don't take life too seriously, it isn't permanent. You might say those are rather fatalistic approaches, but I've always been of the impression that a doctor doesn't save any patients. He or she may influence when and how they die, but he or she doesn't influence whether they will.
Right.
And to me, that was the important thing, to help people through what they have now. So was I one of the greatest surgeons of all time? No, by all means I wasn't. Was I, more skilled in doing certain things than others? I don't think so. I think others could have done them equally well. What I was better at, though, was preparing my patients for what to expect. So over my career, probably some of the most meaningful experiences I've had is when either a patient who is now dying of cancer comes back to me and says, wow, I really appreciate all you've done for me. And I'm sitting here thinking, what did I do? Obviously, I didn't cure your cancer. But they come back and would say that. Or the families, after they had died, would call me up and give me that sort of feedback. You really helped us. Mom always liked to come and see you because she always had a positive feeling once she left. So that's what I did. I mean, I was more of a counselor than I was a miracle worker as far as taking care of these things. I did what I could.
That's interesting to hear. I was actually, when I started residency, I was actually quite interested in ocular oncology. I spent a month during my intern year with Dr. Harbour down at Bascom. But I'll never forget, there was a weekend when I was with you and Dr. Kohea as a third or fourth year medical student, and there was a planned enucleation at the Children's Hospital on a Saturday morning. And I think the night prior to the planned surgery, the child developed new neurological issues. There were some symptoms that hadn't been there before, and so they got a repeat MRI a couple hours prior to our planned surgery. And I think we had found that the cancer had been metastatic. It was in the brain, down the spinal column, and I will never forget the tension that there was when you and Dr. Kohea were talking with the neurologists, the radiologist, to confirm, is this real? Is this really what we're seeing on the imaging? And then making that decision that we're going to have to alter our clinical management, and now we have to walk into that room and tell a mother and father that their child has metastatic cancer that is spread throughout their brain, that's in their spinal column, and we have to talk about, prognosis and how long that child has left to live. That weighed very heavily on me. I said, I don't know if I can do that, but I have a lot of respect for people who do. That's pretty remarkable.
Yeah.
So going back to I find this interesting. Your brother was an optometrist. You decided to become an ophthalmologist. Throughout both of your careers, what was that duality like?
It always worked very well. We have always kept our professional careers pretty much separate, although one of the things he did as he became more of an academic optometrist, in other words, an instructor, and eventually he became an administrator, administrator, director of the outpatient clinics in optometry down at Ohio State, and then became the dean of the College of Optometry at the University of Alabama, Birmingham, and was there for a number of years, and then became the president of the Illinois College of Optometry up in Chicago, and was there for the remainder of his career, just also retired about the same time I did.
Oh, okay.
He would occasionally ask me to come down and actually do video things like this at a much earlier stage in development of the process, but where he would just ask me about various things that he found that the residents would often want to know. Their trainees, their optometry trainees would want to know, and he would just ask me these questions, and I would more or less expound on what I knew about those things and what you needed to tell patients, what you needed to look at. And so I did that. One of the things that I know there are some in ophthalmology who want nothing to do with optometrists because they see them as the enemy. From my perspective, especially having a brother in optometry, my perspective was we have optometrists. We are not going to legislate them out of existence.
Right.
And so we want to have the optometrists trained as well as they can be.
I agree.
So I would provide these kinds of services to them to allow them to then look at those things and maybe learn in a different way than just reading textbooks. So that's kind of how I've interacted with it. Other than that, our clinical careers took very different courses. As I say, he became an administrator. he was very influential while he was in Ohio as a person who would talk with the legislators and be involved in various kinds of committees that the legislature would have, where they would talk about, driving safety and what are requirements for driving, and they did practical things. Well, I didn't have time for that. Yeah. Also, I should add, this is a real difference that I saw, because he, as an administrator, gradually had more and more time to develop policies and talk with, again, legislators and other influence makers, and that was his almost full-time job. Whereas by the time I got to the position of being a department chairman, I had a full-time clinical practice that I had to maintain, plus try to develop policies and procedures and organize the department and get the various people on the staff working in a positive direction. But I didn't have the kind of time that he and other optometrists have to devote toward those things. I was not able to go out and visit with all of my legislators. Right. He learned at the age of, I think, about 50 how to play golf. And he loves golf now. And he gets out there and he plays with all these other influencers. And we don't get a chance to do that.
Right.
And, the few people we have in administrative positions in the American Academy of Ophthalmology do not compensate for that lack of grassroots involvement that the optometrists have.
Yeah. Yeah, I have to agree with you. I think before entering ophthalmology residency, I heard so much about, this clash between ophthalmology and optometry. But quite frankly, my experience has been nothing but positive. I've seen the CEI model. We have optometrists who work at CEI. We have optometrists who are built into our residency curriculum who help teach us. At the VA where we rotate, there's optometry residents we work side by side with. CEI has a couple of optometry residents. All the optometrists I've worked with have been fantastic, and especially as a first-year resident, I learned quite a bit from them because, they went through optometry school and focused on the eye, and I went through medical school and focused on the whole body. But it's interesting that we're at this point where the academy is considering, I think, bringing back optometrists into the fold, and there's been a lot of reactions one way or another from the ophthalmology community, so much so that I think was it Connecticut, there was some survey that was sent out earlier this year where they surveyed ophthalmologists, and I think the question was, should optometrists have AAO membership? And there were a few questions asked, and there was something like 100 or 200 comments listed. And I went through and I read every single one, and they all were variations on two things. One was absolutely, like we're saying, optometrists are our colleagues. They're an integral part of providing eye care. There's not enough ophthalmologists to go around. The number of ophthalmology residency spots really hasn't changed significantly in the past 30, 40 years. So if we're going to provide quality eye care to our country, we have this collaborative model, and absolutely optometrists should have membership or access to the sort of quality conferences and lectures and didactics that we're experiencing. And then the other side seemed to say, we agree with that, but there will always be a vocal minority, or there'll always be a few who really try to take it and run with it and either try to do surgical procedures that they're not trained in, that sort of thing. So it's interesting that I keep hearing about this sort of stuff, especially on the legislative front from a policy perspective, but on a day-to-day basis, at least personally, I haven't had any negative interactions with optometry at all. And it's always interesting speaking to someone who has a close connection, who has a brother who's an optometrist, or like Dr. Linzel, who was an optometrist before going to medical school and then becoming an ophthalmologist. I find that very fascinating because there's other areas of medicine, right, where you have nurse practitioners or mid-level providers who are the model is kind of similar, but not quite. It's a little bit different for us, but it's going to be interesting to see what happens.
It will be interesting, and again, my opinion is my opinion, so it really doesn't influence anything at all. As I said before, we we are not going to legislate optometrists out of practice. They have much more influence than we do.
Yes.
Though, with the legislators, because they know them, they live in their communities, they go to the various kind of civic groups that have their lunches in the middle of the day. We can't do that, and so we're at a disadvantage, even in the administrative levels. So when I was the department chairman, I didn't have the time to do that, and certainly I still maintain unlike my brother who plays golf with these people, I still maintain my track record of never being on a golf course except for a wedding reception.
Wow, that's pretty crazy. You've never been on a golf course apart from that.
Except for things like that.
Wow. I thought what would be very interesting, having you here, is doing a segment where I was wondering if you could maybe give your advice to medical students interested in ophthalmology or ophthalmology residents or even fellows in retina or ocular oncology. How would you approach, or how would you, I guess, teach a beginner how to examine the fundus? Like if I'm sitting in front of you, what would be sort of the overarching themes or techniques you would have me develop?
Well, I've done that for many of the medical students over the years.
And you did it for me when I was a third year medical student.
And it's just one of the things. People, I think many of our colleagues won't even try to get people to do like indirect ophthalmoscopy or fundus biomicroscopy because it's too hard to explain it to them. And I just never accepted that. I mean, I thought medical students are pretty adaptable if they're willing to try. And I would show them everything. First, practical things, how to put the indirect ophthalmoscope on, how to adjust the light, how to adjust the pupillary distance. You have to have everything right, how bright to make the light. And once you've done that, then a lot of times what I would do is have people practice with model eyes too. And that's something I purchased early on so that I would have some available that students could do it. And I would get ones with different sizes of pupils, from widely dilated to undilated ones. And I would have different kinds of ophthalmoscopes available, some with a small pupil option, some with just the broad light, and we would try the various ones. And all I can say is, I would observe them. I could see whether they were getting the light in the eye. I knew what the usual problems are about moving your head versus your hand and lens, and how people get into trouble or are unable to see things because of the way they're moving things. But most of the time, you could get them, even the ones that were not particularly adept, to all of a sudden see some of the images, and again have that
moment, right?
Wow moment that you see that, and once you've seen it and you know that you can do it, then, and if you're willing to practice, then you can develop it. But the main thing that I would say for any of the medical students now, if they're interested, start reading early. Now, I go back on that. Certainly by the time, I read a lot in ophthalmology already as a medical student. Fortunately, we had an old library that was in the administration building to the old Cincinnati General Hospital out facing Burnett Avenue. And that was right next to the A Pavilion, where our clinic used to be for many years, from about 1974 on until we moved over there in about 2012. But at any rate, if I was done with clinic, or if during lunch breaks, if it was, I would go over there. They had these nice leather chairs, and they had all the volumes of Grafey's Archive of Clinical and Experimental Ophthalmology dating back to the 1850s. And I would just go in, pull one off the shelf, and I would start looking through these. And so I remember doing that. I remember, of course, reading the old Asbury and Vaughan clinical ophthalmology textbook early on. And once I got through that one, I read a lot of other small books, and I looked at picture books. But by the time I was in internship, this is what brings it back to me. By the time I was in internship, I would take, every time I got an extra $50, I would buy a volume of Duke Elder's System of Ophthalmology, which was the standard textbook at that time. And I would try to read it almost, at what I would say my free time. I don't know how much free time you have during internship. It's not a lot. But I did, and I went through those. And I had, by the time I started my residency, I had been through almost all of those volumes. I won't say I knew everything, because something that people do misunderstand about me is they often say, oh, he has a fantastic memory. No, I don't. What happens is I have to go back through things multiple times in order to remember them. But I remember the concepts then. I would never be a good actor because I can't remember lines. I can't remember specific things you're supposed to say, but I could finally get the concepts. And once they were there, that didn't leave me. But it took a long while. But I did that. And then also, before ever starting my residency, I had read Rubin's Optics at least a couple times and done all the problems in it. I had read most of the standard Armed Forces Institute of Pathology book. It was a single book at that time, not the 3-volume set that you have now. I had read Wolf's Anatomy. I had tried to read physiology. I found all ophthalmic physiology books to be terrible, I might add, and I still think they are. They're much too research-oriented and not practical explanation of what the concepts are. But at any rate, I had read so much by the time I started my residency that I could then concentrate during residency on learning the techniques. All right, how to do it, how to do these examinations. I knew kind of more or less what I was supposed to look for, but then I used what I probably studied most when I was in residency itself were pictures, the Gass's atlas, and things like that, corneal atlases, things that would allow me to see things and recognize them. The first time I saw them, I'd say, oh yeah, I know that picture. Okay, I've seen that. So I would say start early. Be prepared. Don't think that, oh, we'll get into the residency and then we'll start learning all the anatomy, physiology, pharmacology, everything else on top of how to examine patients and how to deal with the electronic medical record and all the other things that are going on at the same time. If you have your baseline there, your baseline information, you're in a good position to move ahead faster.
I think you did more before officially starting ophthalmology residency than most ophthalmology residents do during their entire residency. But that point's well taken, and I think the medical students who are choosing to pursue ophthalmology today have never been in a better position to study in advance, because now we have all these intern years becoming integrated. Ours was one of the first in the nation, I think, within the first 20 programs where we have, if you match into our residency program, you're also matching into our intern year program. And our residents as interns have 6 months of dedicated time for just ophthalmology.
Right.
They don't have to take call. They don't have to deal with the EHR and worry about documentation. They're there solely to talk with patients, to interact with them, to work on the technical aspects of the exam, and then study. So I think this generation has more advantages than anyone has ever had. But your point is well taken about learning to do indirect ophthalmoscopy. I don't think people realize, even our other physician colleagues, how how many fine movements there are to just the basics of our clinical exam. It's not just you put on a stethoscope, you know the locations for the different heart sounds, or you can do auscultation or palpation. The first time you sit in front of a slit lamp as a medical student, if you've never seen one before, it looks like a foreign object, like an alien, like something out of a movie. How do you use it? There's all these buttons, these knobs, these dials. People can't even find how to turn the light on for a large part. And then you tell someone, okay, you have to take this beam and you have to get it just the right size and height and width, and you have to line it up with the pupil, but you have to have that a certain distance from the patient's eye and a certain distance from your eye, and if you have a refractive error, you have to dial that in or correct that with glasses. And then you have to take your hand and steady it just perfectly, and you're holding a lens and you can't have it too angled. It has to be in the right spot. And once all of that's perfect, now you have to get it in and out of focus, and then you can hopefully see the posterior segment. So there's just a lot of new skills that you have to, that's just looking at the retina.
Right.
There's gonioscopy, there's scleral depression, there's how to do applanation tonometry. There's so many skills that we're either not exposed to or don't learn at all. So I think I think that was very wise of you, what you did, to really focus on the knowledge aspect of things beforehand, so that when you started residency, you could focus on a lot of the technical things.
Yeah, it's interesting that you mentioned that, because one of the books that I did get early on during my residency, and I must say now I've forgotten the author, but was Clinical Methods in Ophthalmology. And it was a book written in the 50s, so it had little diagrams of what you were supposed to do by and large. It didn't even have photographs of most things, but it had clear explanations of how you were supposed to do it and what you were supposed to look at. And so I would read this, and then the next patient I would look at, I would try to do all those things. It's like when you first find aqueous veins and you can see those, and when you first find various kinds of crystals in the cornea and you recognize that pattern, and the various kinds of cataract that you can see, because you've read about it, you know how else to do it. For example, I'll just say, I also learned how to repair all the equipment, which was an early thing too for me, that I figured if I didn't know how to fix it, then I probably really didn't understand it very well. But I remember doing things like even indirect ophthalmoscopy with a transilluminator held up against the eye. And I would hold it so that you could look in a darkened room with even a small pupil with posterior synechii. And often you could, it's not a great view, but you could see the disc, you could see if there's a retinal detachment, you could see if there was a lot of blood, whatever. And that came into actual value sometimes. I was seeing patients in one of the outpatient offices in Philadelphia one time, and the power went out in an electrical storm. And I've got an office full of patients, need their follow-up. And because I knew how to do some of these things, I could still see those patients. And was it quite as good? No, but I didn't have to send them home and cancel them.
Right.
I could still, using my lights and lenses, I could do things with them because I knew how.
That's interesting. Something I remember you really emphasizing when I was a third-year medical student, you were teaching us how to use the indirect ophthalmoscope or how to use a 90 diopter lens. You really emphasize using the different filters on the indirect. And your indirect specifically that you kept and utilized it seemed to have more filters on it than I think some of today's standard one.
Right. Yeah, I did. Well, the main one that was of value, I learned, I started early on using a green or red-free filter and a red filter. Now, the green, it was nice because what would happen is almost all of the green light that is reflected back out of the eye or comes back out of the eye is reflected off either the surface of the retina or the optic disc or the retinal pigment epithelium, or is absorbed by the things that are red. So the blood vessels in the fundus with the green light would look really dark green to almost black, and the background would look a light green against that. And so if you were looking for diabetic retinopathy, for example, it was much easier to see little dots or lines of blood in the retina as little dark dots against a light green background than it was to see them as red dots against a reddish-orange background. And so early on, I said, "Wow, this is a great way of very quickly, without having to do fluorescein angiography or anything, you can see these retinal vascular anomalies. You could see neovascularization of the retina and of the optic disc much better with the green light than you could with the white light. And then for the red light, the red is interesting because it will be reflected back off of red things like blood vessels and the choroidal blood vessels. It would penetrate through and come back from through the retinal pigment epithelium. So it more or less allowed you to look through into the choroid. And so if you had especially a melanotic tumor in the choroid, or a retinal pigment epithelial abnormality, a hypertrophy of the retinal pigment epithelium, it would look almost black against the light red background. If it was a choroidal lesion, it would look dark, but not black like that, and not as well defined. But it would be much easier to see what the margins were when you use the red light. So there were various things that you practice doing them, and you try to do them on every patient until you got familiar with them.
There was something else I noticed, I remember as a medical student, was I think you preferred to examine the posterior segment with the patient sitting up as opposed to laying flat. Was there a specific reason for that? Did you feel like it was easier to examine the far periphery like that, or?
Well, obviously, I would always look at the fundus at least with a non-contact lens. Early on, it was a ruby lens, and then it was the non-contact lenses later on. But so you could see that. Of course, it's 180 degrees inverted then, so it's upside down. But I would do that first. When I did the indirect ophthalmoscopy, I would typically, it was a new patient especially, and I'm looking for a variety of things. I would lie them down on a table, and I would look at them there because the retina kind of settles down if it's a non-regmatogenous detachment. And the nice thing about it is, because essentially if you're then standing at the head of the bed and looking at them, your brain doesn't have to do any transposition. If I'm looking at the right eye, the disc looks to the right of the center, the fovea is just a little to the left of the center. The orientation is correct, so you don't get yourself mixed up. And that's one of the ways that I early on learned how to do it, and then I would learn how to look down, up, right, left, etc. But then also, if they did have serous detachment, you all may also remember then at the end I would sit them up and then see how the detachment shifted in its position. So I would do those things. Now, if I started, especially with a follow-up patient, and I'm just seeing them in the office, I would just have them sit in the chair to do the indirect ophthalmoscopy a lot of times because I knew what I was looking for and when. But if you remember, what I would do then is I would always make sure I turned my chart upside down. Because then when I would draw things, so many times I've seen residents even, when they're jotting something down, because they look at somebody sitting in the chair and then they jot down what they saw, not where it is, because they forgot about the 180-degree rotation that you get. And so there were a variety of reasons, just so that I didn't do that. Did I ever start drawing it in the wrong eye? Yes, I did, and I have some of those that I can show you. And did I ever put it in the wrong spot? Yes, I did, because I would get distracted, but not very often.
Something else that I only remember seeing in your clinic was, so you had a wide variety of lenses as well.
Right.
You had some lenses that were like camera lenses.
And more or less. It was actually early on, the predominant company early on in indirect ophthalmoscopy working under Scapins was American Optical Company. And they made one of the early, very nice indirect ophthalmoscopes, stereoscopic binocular indirect ophthalmoscopes. And as a part of that, they also developed a variety of lenses. Now, the first generation of lenses that they had were pretty bad. They didn't have good coatings, variety of things. But they eventually developed some which were like, there was one in particular which was a 16 diopter lens with a very long cylindrical case, more or less, or holder, I guess you would say, with it, that allowed you to hold this. You had to hold it quite a bit farther away from the patient to get your image, but it gave you great magnification and the square of the linear magnification for the depth. So it'd make things really, if you wanted to look at papilledema, you wanted to look at macular edema, it was wonderful for those kinds of things. So I early on adapted to those lenses, and then I adapted, as I said, to the 28 diopter lens for using for making my standard drawings, etc., rather than a 20 diopter lens. I may have stayed with a 20 diopter lens if I were doing retinal detachment surgery, but since I wasn't, I just found it more convenient to use that lens. But you're right, I used different kinds of lenses for different things. I had 40 diopter lenses too, so that if you really had a relatively small pupil, or if you had a tumor that was quite large and you couldn't even get it all in a 28 diopter lens field, maybe you could get it in a 40 diopter lens field, and that would give you a better understanding of what its true dimensions and its shape were.
So something that you did was, I'm not sure, how many years ago did you stop operating?
Well, I really stopped operating right here in 2018. I mean, but I did a few things. I was not doing well. I was starting to get a tremor in my hand. Most of the last 2 years that Dr. Kohea was here, I just served as her assistant for most of the things. I would, I maybe would start the cases if she was late or something, but if she was there, I would let her do them because she was certainly a much better surgeon than I was, but also at that point in time, I knew that I had my own limitations. But certainly I haven't done anything since early, I'll say, putting some sutures in after taking a radioactive plaque out, and that's about it.
So you stopped doing injections around that same time as well?
Yeah, absolutely.
That's one thing that's fascinating about our field is that we have the ability to see patients in the clinic, but we also can be in the OR as well. Was that tremor, did that just kind of develop very gradually over time, or was that something just kind of in the 2018, 2017 slowly?
It gradually developed, but it wasn't an issue until about 2018. And then it influenced. There are a lot of things that I do that I learned to do as a surgeon with my left hand. For example, I ended up always doing my needle biopsies of intraocular tumors with my left hand. And one of the reasons for that is, of course, when you put the needle in, we were usually doing all these with an indirect ophthalmoscope. And of course, so everything's upside down and backwards. Well, somehow or other, my left hand and my brain worked together that I always knew how to reposition the needle based on what I was seeing. With my right hand, I had to think about it. And I learned that early on, so I always did that. But things like putting sutures in, I was much better doing it with my right hand. Then as the tremor started to develop, that was not becoming very much fun anymore.
Yeah, so you had ways around it. It's interesting that in our field, there's, depending on what study you look at, they say something like 50 to 70% of ophthalmologists end up with cervical spine issues at some point in their career, because especially in retina or ocular oncology, you're constantly kind of, having to look in a sort of odd position, and if you don't really take the time to be deliberate about setting up the exam chair when you start a patient encounter in a busy clinic, it's real easy to put your head forward, bend your neck, flex up the spine. Is that something? I mean, but you've operated for a very long time. You've continued to see patients. Is that something you had to deal with at all in your career?
No, it really didn't affect me. I saw some people at Wills that really bothered them a lot, the retinal surgeons, and yet what I did is, early on, I did purchase a set of loops that were actually ergonomically set, that I would place them in front of my lenses, and keeping my head straight, I could look down at more or less at a reading position
So you had a
do
good
the
angle of
surgery. So
declination.
I didn't have my neck bent a lot of times, like I saw some of the guys doing, and I never ran into that problem. I was lucky.
I kind of like the not the clip-on, but the sort of the portable indirect ophthalmoscopes that you can wear almost like glasses. Those have become very light, and I feel like it puts a lot less stress on the neck than wearing the traditional sort of indirect helmet. And especially in today's day and age where we have these phones and everyone's constantly like this, looking down and having text neck or whatever they call it. I think I try to be very mindful when I, especially as someone, you're tall, very tall as well. You know, the chairs sometimes don't go down far enough, or the slit lamp, we can't raise it high enough. There's a lot of stressors, physical stressors that come from our job, even though people joke that ophthalmologists are sit-down surgeons, you know, for the most part. I think I read an article, I can't remember where, but that compared the physical stress that surgeons undergo relative to people who are in positions where they're constantly doing manual labor.
Right.
And there was a very strong, comparison or similarity between the two, which I found pretty fascinating. That we're in the OR, but what we're doing is actually quite physical.
Yeah, a lot of times it is.
Yeah. You are regarded as a preeminent scholar of ocular oncology and ophthalmology. You're probably one of the most famous ophthalmologists in Cincinnati, and especially in the world of ocular oncology. You've led internationally throughout your career, but one thing you've also done is here at home. You've led and you really helped flourish and in some senses really establish our Department of Ophthalmology here. You were chairman for how many? Two 7-year terms, 2 8-year terms, was it?
Essentially 14, a little over 14 years.
Was it when you were at Wills, and you were at Wills for like 18 years, I think?
Yeah, I was on the faculty there for 18 full years.
Becoming chairman, was that part of what drew you to Cincinnati?
Yeah, that's the only reason I came. When I was turning 50 at Philadelphia, it was really just a little bit before I turned 50, I kind of thought that if I'm ever going to do the department chairman kind of activities, that would be the time to do it, because otherwise, before that, I would have been too young. After that, I would have been too old and not really willing to do it. So I actually looked at a number of programs, none of which really fit me very well, I didn't think. Prior to the opening here in Cincinnati, when Dr. Good stepped down, though, rather abruptly, I might add, he was here for 2 years and announced at a faculty meeting one time that he was leaving to go back to California. And really nobody else in the group even had any inkling of that. So there was an abrupt transition, and there were a lot of problems that were not resolved for a number of years, and so the residency was affected by that. So when I came in here, a couple things I would clarify for you and others, that I was not instrumental in developing the UC-CEI affiliation agreement. That agreement had actually already been signed, developed by the group, and signed the summer before I started. But its implementation was delayed then until the summer of after I arrived here at the first of the year. And so when I came to look at the position here, I had only to rely on my background at Wills and the things that I had done. So I had run a clinical practice, of course, but I had been the director of resident education for a time. I had been the chairman of the OR committee for a time. I was the director of their annual conference for quite a number of years. I was the executive secretary of the Wills Eye Hospital Alumni Society for quite a number of years. And so I had a variety of different things that I had already done, but the main thing about Wills was that it was a private practice arrangement. In other words, the people at Wills are not paid by Wills. They are independent practitioners who rent space from the Wills Institute now, with very few exceptions. The ophthalmic pathologist is paid by them. The ophthalmologist in chief is paid to some extent by them. But by and large, most of the people are paid individually in private practice. So when I came here and I looked at what had gone on, my general comment to them is, I'm familiar with this kind of a situation. The only difference is here we only really have one private practice organization, really two, because we have Children's Hospital as well. So we've got a Children's Hospital group and we've got a Cincinnati Eye Institute group, and then we had a couple people that were just university-based people. And I said, I understand this system and I can make it work. And when I got here, when I accepted the position, I should say too, they had a number of other people who I think were very qualified too, but they had a different kind of a background. And their impression was that somehow it's got to be back to a university-based practice, and that's the way it's got to be. And with me coming in, it was kind of like, no, I think this will work, but we have to make sure that we minimize the downsides, maximize the good sides of this thing, and make this relationship work. And so my job was actually to implement the agreement that had already been developed. Also, at that point in time, I don't think people have any conception in the residency now of where the Children's Hospital was at that time. They had had a full-time director for a number of years, but only a single practitioner in the ophthalmology division.
Wow.
And a couple other faculty people who would go there part-time and help out the residents. And by and large, what the fellow who was here would do was make sure all the paying patients would come to him, and then he'd make sure that the volunteers got to staff the residents and all the non-paying patients. And it's a long story that he was actually asked to leave shortly after, or shortly before I got here and accepted the job. And so one of my jobs was to try to build up the department over there, because it was nothing. And so one of the things that I did is I really was the first person who ever actually appointed any women and minorities to the department. There had been Dr. Asbury's mother, who is a part-time person, had been the ophthalmic pathologist back in the 1930s to 50s. But other than that, there had been nobody else. There had been no minorities. There had been no women who had any full-time position. I think there had been only 3 women residents up to that point in time. So at any rate, to get this story short, one of my first roles was to look at candidates along with the children's people that we could get in there to take over that position, and we found that Connie West would be the appropriate person to take care of that. She turned out to be an outstanding program builder. In relatively short order, she brought in Dr. Young, and then she brought in several other people, some of which there was a little transition for a while, but then it gradually got bigger and bigger and bigger, and obviously then it made this transition over to Dr. Young as the chairman, and with a large staff and growing every year, and it's a phenomenal thing. So they were growing, and the Cincinnati Eye Institute people were working to integrate that program with the university and make sure that the residents didn't get shortchanged. Well, as a matter of fact, they didn't. I think they got many of the benefits from that. Plus, we started a bunch of fellowship programs, which until that time, the only fellowship program that was here was in oculoplastics, started by Dwight Coolman and worked with Bob Kirsten, and then, of course, with Jeff Neerad after Bob Kirsten had left. But I just kind of pushed to say, look, we've now developed such a big group of various specialists in the various areas, subspecialists, and I really pushed them to get the retina fellowship started, the glaucoma fellowship started, the cornea fellowship. Of course, when Ed Holland came in, he brought the fellowship with him, so that helped too. Then they started the pediatric ophthalmology fellowship, and I think all of those programs actually helped the residents, because those people also who were in the fellowship positions were in a position to help train the residents as well.
Right.
And they turned out to be outstanding people. So, and again, that reflected back on my experience at Wills, and how in some programs the fellows would take all the cases from the residents. And that I didn't think would ever happen here, because that's not what happened in Philadelphia. It really worked for both of them. And so that's really what I did. I came in and I made sure that the programs worked, and that we tried to encourage people to take part wherever they could, and I supported them wherever it was possible, and I think the rest is history.
But you were also instrumental in a number of other big changes to our residency program, to our department, that I don't think a lot of people, at least in my generation, are aware of. Like you expanded the residency from 9 to 12. Is that correct?
Right. Correct. It had been, it's an interesting thing. Back when Medicare was initially instituted, back in the 1980s, the chairman at that time, Dr. Sachs, said, well, he could have appointed more residents, but he thought he would be a good citizen, and he didn't know that the residents needed that much more experience, or that it would dilute their experience if they took more residents in. So he decided that no, we won't do that. At the same time, Ohio State went from like 3 or 4 residents up to 8, and they were all paid for, because then they were more or less grandfathered in. However many you got at that point in time, that's how many you had. Well, then subsequently, if they ever wanted to expand the residency here, there was no money to expand it. Your total complement of residents were set back at those from that time based on how many you had at that point. And if you ever wanted more, you had to apply to Residency Review Committee and whatnot. Well, it turned out to be very hard. I had to go through all kinds of manipulations to get CEI, Children's Hospital, the VA, and the university all to agree to contribute back to this thing, even though they weren't getting any extra money for it, to add the extra residents. So we were able to do that. But it wasn't an easy process. Also, working with Josh Sands, we were able to really develop the VA program. And that was going wonderfully until the VA decided to put an optometrist in charge of the surgical program. And that caused a real major hiccup for about 1.5 years, 2 years. I think it's pretty well back in order right at this point in time now. But Josh also helped to get the VA to develop the new eye center. And so we have much better facilities now for the residents than we used to have. That was an outstanding addition too. We also got some additional endowed chairs while I was here, which was an important thing. It's something that most of the residents and other people don't know, is we did have a potential donor in town who had been involved in the LASIK Plus Center. And he came to me with an offer that he would give us $50 million. But for that $50 million, we would have to develop a new optometry college as part of the University of Cincinnati and develop an optometry program here. And I know how much it costs to build buildings. I know how much it costs to maintain buildings. I know how much it costs to get the faculty in that you would need to run a program like that. And also knowing that Ohio State already had an optometry program in Columbus, right there next to the legislature, which was well funded, we were unlikely to get any state support for this thing. So I could see, yeah, we could put the money into physical plant and faculty members for a while, and then the money would run out. Sure. So it sounds great, but I had to turn it down, and I tried to get him instead to name the department after him and let us set it up into multiple other endowed chairs and funds that we could support from that. And I think he did something else with it.
That's interesting. But before you were here at Cincinnati, or at least returning to Cincinnati, was there an ocular oncology service there?
No.
You founded it, right? You were the
right,
first director.
Right. There was nobody in Ohio, actually, who had ever had. I mean, very few people, when I started, were doing ocular oncology. There was Evan Grigudis, who does the proton beam up in Boston. There was Jerry Shields, who I joined in Philadelphia. Don Gass was kind of a diagnostic person on tumors in the eye, but he really wasn't very much of a therapist for them. There was Bob Ellsworth, who worked with retinoblastoma in New York City. There was Devron Char, who was out in San Francisco. And really nobody else beyond those really specialized in eye tumors. They might see some eye tumors as part of their practice, but that was really it. So when I joined and David Abramson joined Bob Ellsworth around that same time, we were kind of that generation in there. And so there were only about 7 of us, I would say, at that point.
How many ocular oncologists do you think are in the U.S.
Well,
right now?
since that time, since then, that time, there have been a number of ones that have been trained so that at least most of the major university medical centers now have somebody that does ocular oncology at least as a half-time job. So exactly how many I don't know, though. I really don't.
In addition to ocular oncology here, you were instrumental in founding a lot of the other subspecialties, at least formally here as well, correct?
I guess I don't understand.
Like retina or
well, I mean, no. I mean, obviously, before I got here and under Dr. Sachs' direction, they had developed a retina service. They had developed a cornea service, uveitis, or the glaucoma, the things like that. So they were here. But then when they merged with CEI, which CEI had developed their own service independently, and part of the arrangement with CEI, the affiliation, was that those people were gradually going to merge into those. So no, I really didn't have any influence on that. Those were established, but they grew under the direction that I had. I mean, I was supportive of them, and I think, yeah, each of the services grew with, I mean, I look at the glaucoma service now. Right. It's such a big group. The retina service is we've got a number of people doing the anterior segment surgery. Obviously we brought in another person now to do posterior uveitis instead of anterior uveitis, and so it really has developed a lot.
It's interesting. Something that you've done throughout the past couple years, in addition to your research, is you've been documenting the history of ophthalmology in Cincinnati. You gave a grand rounds talk, was it earlier this year, end of last year? Mm-hmm. That was very eye-opening, a lot of stuff that I didn't know about. Mm-hmm. And then just this year, I think, right? You published at least the first edition of this book. Right. That clearly is a labor of love.
Right. Back in 1994, Dr. Asbury had prepared the first history of the department. It really wasn't a history of the department, it was history of ophthalmology, he said, in Cincinnati. And it was just kind of like little anecdotes about certain people who were prominent ophthalmologists during the 1800s, and then a very short bit about some of the people who had been the department chairman in the subsequent years. It wasn't in any great depth. When I got here in 1999, I kind of looked at that and I said, we ought to have a little more than that. And I actually worked with him in 2002 to update that and put a few more things in it. And we really used that to give that to the incoming residents so that they knew a little bit about the program. But it still didn't have very much information about the program itself. And in talking with even Dr. Asbury about it, I found that there were a lot of holes in what was known about the program. For example, when did the residency start? Who started it? A lot of things like that. And so I just decided that that would be an interesting thing to try to find that out. So starting even about 5 or 6 years ago, I started to in my free time, collect some information in books. I read through a variety of books about the University of Cincinnati and how it was developed, and about Daniel Drake and where he came from, and a variety of different people, and then subsequently followed that up with all sorts of things about the former chairman, and from that, and looking at their bibliographies, tracking other things down, and then finding out what was happening in Cincinnati at the same time as that. And finally, after I stopped seeing patients, I was able to then put all those things together. So between January and March of this year, I was able to put all of it together, get all the pictures I had collected together, and put them all together in what I called a comprehensive history of the Department of Ophthalmology, its residency program, and its subspecialty fellowships between 1896 and 2019. Actually, I talked about a lot of things that happened even in the late 1700s and early 1800s as precedents to this, but the Department of Ophthalmology was only formed, the College of Medicine was only formed as a university-based college of medicine in 1896. So that's why that date is important going forward. And so I was able to do that. I was able to find that the residency program started in the mid-1920s as an eye, ear, nose, and throat residency. And I found that interesting too. It was run by a guy who was an otolaryngologist. It's very difficult even to track down, even with what I was able to find, what the ophthalmology practitioners on the staff had to do as part of that residency program, or whether they had any supervisory role at all. It doesn't appear to be. It seems like early on, a resident was a resident if he said he wanted to have more experience with that particular specialty. And so when he came to the hospital, it was up to him, and it was always him for many, many years, to learn by trial and error, read about something and try it, and with almost no supervision at all. And it didn't seem like even that changed very much until Dr. Asbury came on as the residency program director in 1956, and really started to insist that we had some supervision, even though I will tell you, even then, as a senior resident here, you would be able to schedule cases on your own if you derived them from your clinic. And unless it was very complicated and you didn't feel that you were competent to do that, you didn't have to have anybody. So as a resident even, it was very hard to get anybody. Dr. Raymond was the only person on the staff at the start here. And Dr. Raymond was a very slow surgeon. He could do one surgical case in the morning and one surgical case in the afternoon, and that was it. And so if you had a retinal detachment come into the clinic and he had some cases scheduled for the next 2 weeks, it would be a long time. So I would schedule them. I think I did about 7 retinal detachment procedures on my own without any staff supervision at all. And I got about 75% of them attached. Didn't get them all.
That's pretty
and
remarkable.
I look back at the fundus drawings. The ones I didn't get attached had giant tears, PVR, things like that. Well, it's no surprise that I couldn't get them attached without vitrectomy methods.
Yeah, there was somewhere in the book, so I've been slowly going through this. I'm probably about halfway, although what I've started doing is, rather than reading it start to finish, I've been jumping from section to section.
Which you can, right?
There was somewhere in there that I remember you writing that a lot of the residents would do cataract surgeries on their own, right, and they were staffed by the more senior residents, and
right,
there was usually not a faculty member or attending present.
Yeah, when I started out, the way it worked out was the senior resident would be doing the cataract surgery. The first one that he would do with you, he would show you what he's doing, and he would talk through the case to explain what procedures he was doing right now. And then the next time, he might do that again for a few times, but then he would then, if you were attentive and paying attention, he would then let you make the conjunctival incision, and then maybe put a suture or two in the conjunctiva when you got done. And then later on, then you would be able to make a part of the corneoscleral incision, keeping in mind we were doing intracapsular cataract surgery at that time. And so, but at any rate, so that as a first-year resident, you would work with the third-year resident. If you had a good third-year resident, it was a great experience. If you didn't, it might not be so good. Fortunately, I had a great guy. So it worked out well, but you would gradually be able to do more and more of the steps until eventually he would allow you to do one case all the way through that day. And he had several that he would do, but he would do 4 or 5 that day, and then you would do one. And so it worked out well. And then your second year, then we typically worked with just one guy most of the time, Dr. Rowe, who was there then, and he would let you work on his private cases. He was the first full-time person here in the department. He never had a real big practice, but it was big enough, and he was a very pleasant guy, and he would let you do things, and he would talk all the way through it too. And many of you didn't hit on this part. You probably remember from when I was seeing patients, I would always talk all the way through my patient exams. So the cornea looks fine.
That's right, you would. That's right.
The anterior chamber looks deep. The iris looks normal. It's a light blue color. The lens looks clear, or whatever it has. And I would go through all these things, and I picked that up from Dr. Rowe. And I saw that it was extremely reassuring to the patients. And I just said, yeah, it's a natural thing. That's just something I'm going to do. And a lot of the guys would just feel ill at ease doing that, and I'm sure they do, and they would never do that. But it's something that I picked up from him. He was great about that. But anyway, he would let us do some of the cataract surgery. He would do 1 or 2 himself, and then let us do at least major parts of some, and then if we were doing a good job, let us do the whole case on his private patients even.
Yeah, I'd forgotten you used to sort of dictate out loud almost. In a
sense.
But
nobody was taking notes though, except I was thinking of it. I was remembering. It was my way of remembering that I had looked at it and that this is what it was. Then I'd go back later and make my notes.
And one of your favorite adjectives, I remember you love to describe things as quiet, correct?
Well, there were certain things that obviously I didn't like. I didn't. Like that the conjunctiva could be angry because I didn't think it would have any particular feelings. I didn't think that the anterior chamber would ever be quiet or loud. I guess that would be the opposite of that. But so certain things like that really would set me off.
Yeah, it was interesting. We just had that Grand Rounds presentation earlier this week, and one of the residents was referring to Labors as Liebers,
right? Lieber,
and you made a comment on that. It reminded me of the skit our graduating seniors did, where they had you and they kept describing something as quiet, and you was slowly zooming in on you, and you said, "That's it, I'm coming out of retirement."
That's right.
But I think just being very particular about verbiage or pronunciation, that sort of thing, I think it speaks to your passion for propagating a certain way, the right way of doing things, of preserving that, and then passing it down from generation to generation. One thing that I found interesting just reading through this book is how much the history of ophthalmology here in Cincinnati is kind of tied to the medical center. I mean, we're sitting right now in a room that's on the cusp of the Care Crawley building. And just reading through one of these sections there, you know, the Vision Research Center, a lot of that came through the big endowment that helped establish this building. That was all kind of ophthalmology related, correct?
Right. Well, Mrs. Crawley was a former patient here in the department, a graduate actually of the College of Law here, who went into teaching. She never practiced as a lawyer, lived out near Muncie, Indiana, and whenever she had some spare money, she would buy land around there. And she lived very modestly. She never was ostentatious about anything. And when she died, I don't think many people had any idea how much she was worth. At any rate, she had been treated here in our department. She had seen a number of other people with complaints of vision that seemed to it was really bad always in the morning, and then it seemed to get a little better later in the day. And everybody would see her late in the afternoon, and they never could find anything wrong with her. But she had mentioned this to Dr. Sachs, and he had said, well, why don't we have you stay overnight and let's look at you first thing in the morning? And did that. And found that she did have a shallow retinal detachment, that then when she would sit up, it would slowly migrate downward, and she would start to see better during the day. And it turned out she had a very small retinal break inferiorly in the periphery. He turned her over to Dr. Raymond. Dr. Raymond did a scleral buckling procedure on her. It closed the break, and her vision problem stopped. She was very appreciative, especially since other people had not been able to find this and treat it. So when she died, we didn't know. We didn't know whether we would get some money, any money, little money, but she donated the bulk of her estate, which was almost $13 million, to the College of Medicine and specifically the Department of Ophthalmology, with the understanding that half of it would go toward construction of a new facility where a research laboratory would be housed. And the other half would go toward what she called a scholars fund, but essentially a faculty support fund that we could use to support both faculty members and fellows and whatnot, and the reagents that they needed and the instruments that they needed. And it turned out to be very helpful. They were in the process of planning the Care Crawley building. They worked with her family representatives to find out would that be okay if they put her name on the building and put the lab in this newly constructed building, that she would have her name on it, and that would go toward that building. So that's how this came to be.
And then there was a sort of an interesting story I thought was with essentially the Dr. E. Vernon and Eloise Smith chair or endowed chair we have.
Yeah, Dr. Smith was an internist in Cincinnati already in his 80s when I first met him. So he had been retired for a number of years, but he had developed macular degeneration, wet macular degeneration in one eye, and had been lasered, which was the treatment that was available at that time for a juxtafoveal choroidal neovascularization by one of the people at Cincinnati Eye Institute. Well, his vision was instantly worse and permanently worse in that eye after the treatment, not because the treatment was bad, but often because at that time you would try to burn this choroidal neovascular membrane to close it, and if it was close enough to the fovea, sometime the burn would extend out and get to the fovea, and the visual acuity would go down. And at that point in time, it was clear that the ultimate visual outcome of eyes that had that treatment done was generally better than the ultimate visual outcome of eyes that weren't treated by that method. But it didn't make any difference to patients who were worse. And so he was very upset about that. His wife they had married later in life. His wife had then developed some dementia problems and had passed away actually several years before I even met him. But he always talked about her very, very nicely. And at any rate, so I got involved when I came here because he came to the group that Dr. Asbury and Dr. Good had established called Quest for Vision. He got a bunch of community people together who had some interest in eyes, particular macular degeneration, and we had little seminars about it and told them what we were doing in terms of research, what was available, and that sort of thing. And they really started to support us quite well. And Dr. Smith, of course, was very interested in that. I didn't say also his mother had become legally blind in both eyes before she died from macular degeneration. So he was quite sure that was going to happen to him too. So I kind of took him under my wing, and I would examine him periodically and just talk to him. And when he felt he was having problems, I would get somebody else in, Dr. Hutchins typically here. One time I remember he said, well, he found out that they were really doing some wonderful things at Johns Hopkins, and he wondered if he should go there. And so rather than acting defensive about, oh, they're not going to do anything different, I said, oh, that's a great idea. Let me help you get that set up. And I called some people there. We got it set up. He got in there. They took a lot of his money, and they did the same tests that we had done and came out with the same recommendation that we had had. And so he came back and was, again, very appreciative because now he kind of recognized that we were telling him what was the appropriate thing, just felt reassured. And he would often say to me, what can I do for your department? And I knew enough as a former fundraiser even in Philadelphia to say, well, Dr. Smith, it's not what I want or need, it's what would you want this money to go for? And he would think about it for a while, and then we'd come back to it later and whatnot. He often would say to me, though, he wanted me to teach the residents and fellows to act like me. Now, whether that's appropriate or not, I don't know. But that was he wanted them to, and I said, Dr. Smith, I'm not sure I can do that. I can show them by example. I can't, make them be like me, but I can at least do that, and I would assure him of that. So at any rate, when he eventually died, shortly before he died, actually, he set it up that he was going to establish an endowed chair, principally in my name. It was going to be for the chairman of the department. Right. And we had it named after him and his wife, Dr. E. Vernon and Eloise Smith Chair. And the one thing is, though, he wrote into the proposal, without any input from me whatsoever, that even though it's for the chairman of the department, that for as long as Dr. Augsburger is at the University of Cincinnati in any position, that the endowment monies or the income from the endowment goes to him. So that's one of the reasons I can do, but it's another interesting thing here. If I were doing this research here and I could not get paid for it, for example, I'm not producing any patient care related revenues, things like that, I'm not sure how I could do it. Yeah. But with that endowment, I'm able to support doing that and pay for the things that I need to do in that National Death Index search, for example.
I think that's amazing. That really speaks to, I think, you as a clinician and as a human being, that you had that impact on someone else, so much so that they said specifically, while Dr. Augsburger's here, I want him to have that.
It was very nice.
One thing that was interesting in here, and maybe the last part regarding this book, was that I saw that you mentioned that you had decided prior to becoming chairman that you were only going to do maximum 2
Right.
two sort of stints.
Well, let me just tell you, you do that on the basis of your prior experience, and I had seen people who stayed on too long. I was the program director at Wills under Thomas Duane, who many people don't remember him anymore, but he was in charge of what they called the Duane series of ophthalmology, which was a prominent textbook that followed the Duke Elder series by a few years. At any rate, he probably stayed on a little bit longer than he should have, started to develop some dementia problems, and fortunately stepped down shortly thereafter. They did bring a person in, didn't work out real well for a while, then Dr. Tasman was appointed. And unfortunately, from my perspective, Dr. Tasman stayed on in that position until he was in his 80s. And he was making decisions that were going to affect the future, even though it would have no impact on him at all. And from my perspective, I just could not see that that was a rational thing to do. Also, at the same time, the chairman at the Hahnemann Drexel University was a similar guy, Myron Yanoff, who had been the department chairman for many, many years, and again stayed until they closed down the program into his 80s. And I just couldn't see doing that. So I came in here, I had just turned 51 at the time, and I said, I'll do this until I'm about 65, and then I need to turn it over at that point in time. So I made that arrangement. I told the dean about 18 months before I was going to step down that I would step down, and there's a variety of things that are a little strange about that. But nevertheless, and then when that time came, I did, and I felt never look back.
And you told the dean that 18 months in advance that it was going to happen,
yeah,
and
that's
yet a
all
search
right.
didn't start.
So the story is, I told him that so that he could start a search, knowing that when Dr. Good had stepped down, that there was that abrupt transition. It took almost 2 years before they appointed me as the next full-time chairman. And I said, let's avoid that now. Let's get started on this. Well, he did nothing. So 3 months later, I went back to him and I said, I told you I was going to do it. And then after that meeting, I put it in writing to him. And he still did nothing. And then another 6 months went by and nothing had happened. And so now it's going to be another 6 months before I'm ending. And finally, at that point, I told him, I wrote it to him in a letter, and I sent a copy of it with it to the president of the university. And the reason I did that is because we at that time had some grant monies from Research to Prevent Blindness. And Research to Prevent Blindness had some rules. It's a private organization, so they can have whatever rules they want. But one of the rules was, as long as you have a permanent chairman and there's no transition, your funding from them, if you've established it, can continue. But if there's any gap in the full-time chairman position, then the funding stops. And once a new chairperson is appointed, he has to be or she has to be in that position for at least 2 full years before you can even apply for any more funding. And then you have to apply for half the funding you were getting before, and you have to fill out much more detailed information, which I had done when I first got here. We went back and looked at the numbers on that. If we were to lose this, we would literally lose well over $1.5 million in funding support. Still nothing happened. And by the time I finally stepped down, there was still no committee had been formed. And so the day that I was to schedule, he asked me if I would stay on for a while until they find somebody else. And I looked at it and I said, under no circumstances would I do that. I gave you 18 months.
That's bizarre.
And well, his comment to me was that the Research to Prevent Blindness requirements were silly. And I kind of looked at him. I don't care what you think of them. Those are their rules.
Right.
And so he didn't do anything. And then actually, it was still over a month, maybe over a month before he even then started to form a committee after that to then look at various candidates. Dr. Golnick was good enough to take over as the acting chairman of the program. It took them a year then to appoint him. And it just such a waste.
Yeah. But I mean, at least it was sort of internal in the sense that Dr. Golnick was already here.
Right.
It
wasn't a difficult transition.
Right.
That's right. It wasn't a difficult transition, but they didn't need to lose $1.5 million to do it.
So since then, have we reapplied? Have we gotten some of that back?
I don't even know. I suspect that Carl has done it, but I stayed out of the loop on that one. Now, of course, I guess he would have had to have done it here recently. So I don't know.
So we've talked a lot about your career, what you've done in ophthalmology. Now that you've sort of retired and you have a little bit more free time to focus on your research, on sort of what you did for the history here, do you find you're having more time to travel and lecture and still do teaching?
Well, the answer is I have more time in a sense. I've written a number of other papers that are still kind of in the process of getting published. But at this point in time, I'm now in a position to go back through the rest of the chart information we talked about earlier, and I think there'll be quite a number of publications coming out of that. So I'm probably looking at somewhat of a hiatus in going to many of the meetings and lecturing until I get through some of that. So I'm typically now going to only 1 or 2 meetings a year. Right now, I'm going to one, for example, the European Retina Society called the Club Jules Gonan in Croatia this coming September, and things like that. But it's only 1 a year, and then we'll couple that with some vacation time over there while we're there. But I think once we get the other long-term retrospective analyses done, then what I'm going to be able to do is get back on the lecture circuit some more and talk about what those results are.
Mm-hmm. Well, thank you so much, Dr. Augsburger. It was a pleasure getting to know you and working with you as a medical student, but even as a resident, I'm glad that you're still here, you still give lectures. Thank you for taking the time this morning out of your research schedule to talk with me here today. This was fantastic. I learned a lot.
You're quite welcome.
All right. Appreciate it.
All righty.